You are now listening to Surelgar MD.
Sorrel RMD. So recently I've been able to practice a little bit of peripheral arterial disease, and I figured it's kind of a tough subject. I know that there's a lot of radiologists, interventional radiologists, that just don't know anything about the disease, and I just want to talk a little bit about it because it's not this impossible thing to understand. It's actually pretty straightforward once you get to see it a little bit. So let's just chat a little bit about peripheral arterial disease. So peripheral arterial disease, we're talking about disease of the lower extremities. So your legs. We're talking about the major conduits of arterial blood flow that extend down our legs. So starts in the pelvis, right? We have our iliacs. We have common iliacs, that's the bifurcation. External iliacs come down to the groin. Common femorals, a short segment in the groin. Then we have our SFA, a big highway of blood flow going all the way down our thighs. Get to the knee, we call that popliteal. Popliteal refers to knee, so that's popliteal. Then below the knee, the popliteal bifurcates into anterior tibial and TP trunk, and you basically end up having three vessels that go down to the ankle and the foot and supply the foot. So that's peripheral arterial. That's the, that is where things go down. That's understanding the anatomy, grossly. Peripheral arterial disease is all about not getting enough blood flow to the lower extremities. And, how do we get evidence of that? How do we get evidence of that clinically? We can extrapolate a lot of the things we already know about heart disease. When you have disease in your coronary artery, you may get chest pain, you may get shortness of breath, right? Think about what the arteries of the leg are supplying. It's supplying your muscles, right? It's supplying your nerves, and it's supplying your bones, all right? If you don't have enough blood flow to your muscles, you're going to get pain. You're going to get pain either at rest or when you do some exertion, like maybe walking a few blocks, you're going to get pain. So that's a symptom. If your nerves aren't getting enough blood flow, you're going to get funny feeling in your nerves. You're going to get paresthesias. If your bones are not getting enough blood flow, theoretically you're going to get an infection of the bone. You're going to have bacteria actually finding your bone as a place to live. We call that osteomyelitis. All right? So these are all things that can happen when you have poor circulation to the legs. What can we do about it? Really, all we can do about it as an interventional radiologist using procedures, what we can do is we can find a way to improve the blood flow. And that comes first from we diagnose where is the blockage in the blood flow. We can diagnose that as radiologists. And then how can we most effectively treat that decrease in blood flow? And that's using all the tools that we have in interventional radiology. And the most important tool back then and now is a simple angioplasty balloon. A balloon that we inflate inside the blood vessel with a high pressure using an insufflation device, basically a pressurized syringe. We inflate that balloon inside the blood vessel, open up the arterial blood flow, improve the blood flow, and then hopefully, demonstrate that we have decreased symptomatology, decreased pain, improved ability of someone to walk, decreased paresthesias, all right, and just documenting these in different forms. But most importantly, clinically, does the patient feel better? Right? So that's really all PAD is, kind of in a nutshell. And physically the cases, as IRs, we have these skills. Typical case is like this. Let's say there's a big SFA lesion. There's a tight stenosis in the mid SFA. It's a nice straightforward lesion to understand. It's decreasing blood flow down the thigh into the leg, into the lower leg, and we could treat this with a balloon probably. So let's say the lesion's in the left SFA. I would stick the right groin, all right, 5 French sheath, come up and over. How do you do that? You take a flush catheter. You do a flush aortogram over the bifurcation. Then you extend a Benson wire, pull it down slowly till it breaks the bifurcation. Toss the wire down the left lower extremity. All right. You can chase it with the flush catheter, or you can then exchange it for a angled catheter. and then start working into the leg. Get a little bit of stiff wire purchase into the leg, and then take an up and over sheath, like a 6 French up and over sheath, and just bring it down to the left common femoral artery and start working. You can image the leg arteries with that sheath, and then you can put through that sheath a catheter and a wire, say an angled catheter and a glide wire, and start working through those narrowings in the blood vessels. When you get past a narrowing, exchange out for a balloon catheter, inflate the balloon under fluoroscopic guidance, and then image and see, have you improved blood flow? That is a very basic outline of a case. I have done such a case, and I can tell you it's very empowering. It feels good. We're using our skills, and there's a lot of this disease out there. There is so much of it out there. It really is an issue of diagnosing it effectively as a diagnostic radiologist, identifying it, communicating that to the patients and the other doctors, and then getting those patients on the table. Bottom line. So that's PAD in a real brief nutshell. Nothing too crazy to understand. Nothing, you don't have to go in depth and look at a lot of trials. You don't have to read up about rotary atherectomy devices. All you need to do is understand that we're trying to improve blood flow to the lower extremities using the skills we have as diagnosticians, as interventionalists. So that's all I got for now. Cerebral MD.